case basis depending on the
Yes.
variables in that case. Right.
Yes.
Thank you so much.
So we need to give antibiotics as early as possible. We should give them broad spectrum antibiotics. We assess the treatment daily. So there are certain situations where we need to give combination therapy. That means combination of antibiotics. I'll be going into a little bit of more details in next few slides. And the duration of therapy will vary depending upon the site of infection or the origin of infection, whether it is community acquired or it is hospital acquired or it is by MDR organism or susceptible organism. When if you are not able to find an infection, then there is something called as procalcitonin level measurement. So procalcitonin, will see that how does procalcitonin help in de-escalation of antibiotics. So we have seen we have to early and appropriate antibiotics. Early means that within 1 hour of recognition of sepsis and shock, we need to give them antibiotics. But another important aspect is we need to understand what is appropriate antibiotic therapy. Appropriate means we need to decide what is the route of administration, whether we need to give them oral antibiotic, IV antibiotic, what is the dose, what is the frequency, what is the penetration of that antibiotics, and what is the bactericidal or bacteriostatic activity of that antibiotic. So route of administration will depend upon your patient situation. Supposedly you have a patient who is conscious oriented, able to cooperate, you can give them oral antibiotics if your oral antibiotic and IV antibiotic has same bioavailability. That means you are able to achieve the levels by oral administration as well as IV administration. Such antibiotics include fluoroquinolones like levofloxacin, moxifloxacin, or clindamycin. They can be used IV. Linezolid, you can give IV or oral because their bioavailability is very good by oral route also. And supposedly you start a patient today on levofloxacin, which is intravenous, and after 2 days your patient is much better, he's sitting, eating well. That means that day you need to make it oral. So your route of administration will also change depending upon patient's improvement. Your dosage and frequency will also change. Supposedly your patient today has come in renal failure, he has sepsis with renal failure. Your initial dose prescription may be low dose because of the renal failure, but on day 3 or day 4, if your patient's renal function has normalized, he has responded to your therapy, you need to increase the dose again as the usual dose. So all these things need to be seen baseline and should be followed up depending upon patient's progression and improvement of his illness. So this we have seen that what are the risk factors for multi-drug resistant organism. This part of slide shows what are the risks for fungal infection in patients who have suspected sepsis. So use of broad spectrum antibiotics. So this part of slide will probably, we will be looking at patients who are hospitalized and have an hospital acquired sepsis. So all these things like a patient who has been in ICU on broad spectrum antibiotics for a few days, who has had a central venous catheter or a parenteral nutrition, hematologic malignancies, immunosuppression. So in these patients, you need to consider fungal infection as well. So now by each source will be going to the important antibiotics which we can prescribe. Supposedly you have a sepsis which you have presumed due to pulmonary source. So if you have a community acquired pneumonia, the antibiotic regimen will include a beta-lactam along with a macrolide. So this is the most important and most commonly used regimen in most of the settings. That means you will have beta-lactam, which can include ceftriaxone, cefotaxime, ampicillin. So this will vary depending upon your hospital's flora, hospital's choice. Sometimes if you are working in a public hospital, this antibiotic choice will vary upon what is available in your hospital, what is under the supply. So all this will vary, but this is the basic principle that you need to give one beta-lactam and one macrolide, which is usually azithromycin or clarithromycin. Alternately, you can use beta-lactam along with the respiratory fluoroquinolone. Respiratory fluoroquinolone will include levofloxacin or moxifloxacin. In our country, we tend to avoid more of respiratory fluoroquinolones in community-acquired infections because they are now used for treatment of tuberculosis, and it can lead to drug resistance or missing the diagnosis of TB in patients with community-acquired pneumonia. So you should not prescribe levofloxacin or moxifloxacin unless you have ruled out TB conclusively in a patient with community-acquired pneumonia. So that's why the beta and azithromycin combination remains the first choice, and it works very well for most of these patients. For patients who have hospital-acquired pneumonia, you need to give them anti-pseudomonal. So here we have to understand that these are the patients who have a high risk of MDR infection. So you need to give them anti-pseudomonal beta-lactam along with the anti-pseudomonal fluoroquinolone with MRSA. That means you need to treat Staphylococcus aureus also. So you can give them vancomycin or linezolid. So this is for hospital-acquired and community-acquired pneumonia. If you have catheter-related bloodstream infection, sepsis, you can use in these patients, if you see bloodstream infection, the common organism is Staphylococcus. So you can have Staphylococcus aureus or epidermidis. So you need to give them staph coverage by vancomycin or daptomycin along with the anti-pseudomonal beta-lactam with or without an aminoglycoside. And if these patients have risk factors for fungal infection, you need to add a fluconazole or echinocandin depending upon your availability and resistant rates. For sepsis from urinary source, third generation cephalosporin along with an aminoglycoside, that means ceftriaxone or cefotaxime, amikacin or gentamicin remains a very good choice. And for patients who have undergone urological intervention, you need to give them anti-pseudomonal antibiotic. And this is a common scenario if you have patient where there is sepsis but you are not able to ascertain the source of sepsis. So you need to give them anti-pseudomonal beta-lactam such as piperacillin tazobactam along with an aminoglycoside or an anti-pseudomonal fluoroquinolone with vancomycin. So this 3-drug regimen is for initial only, and as you get the diagnosis or source of sepsis, you need to de-escalate. There may be regional variations in this antibiotic regimen. Some people will choose ceftriaxone along with azithromycin. Some will choose ceftriaxone along with fluoroquinolone. Some may give vancomycin, some may not give vancomycin. So that will depend upon how common an staph aureus infection is in the area. So commonly used regimens in this include piperacillin tazobactam with azithromycin, piperacillin tazobactam with levofloxacin, piperacillin tazobactam, azithromycin and vancomycin. Sometimes people tend to use ceftriaxone more often. Sometimes people tend to use doxycycline in view of tropical infection. So this sepsis from unknown source will have different regimen depending upon your local suspicion and commonality of organisms which cause this infection. So now we come to the role of procalcitonin. So procalcitonin is a marker which is released by tissue in response to bacterial infection. So it's like a biomarker of bacterial infection. It is more specific than WBC count or a raised WBC count or raised CRP. But as the infection starts clearing, procalcitonin levels tend to fall. So you can use procalcitonin level to de-escalate antibiotics. Supposedly, you had a patient who had high procalcitonin, he had sepsis, you started him on treatment. Procalcitonin levels have become very low. That means below less than 0.2025. That means that is the time when you can start your therapy. So studies have shown that if you use procalcitonin for de-escalation of antibiotics, you reduce the antibiotic exposure. And some of the studies have actually shown that use of procalcitonin may lead to reduction in mortality as well. So procalcitonin, it may not be available everywhere, but it is an important biomarker to de-escalate antibiotic therapy in sepsis. So after discussion of antibiotics, if there are any more questions, we can discuss them.
There are questions, but I think we can complete the discussion and then go towards questions because there are.
I'm not able to listen to you.
Yeah, are you able to hear me?
Yes, sir.
Yeah, sorry. So I think we can take the questions later on. For now, let's continue with the discussion, and towards the end, we'll take the questions.
Okay.
Right. Thank you.
So now we come to the fourth point, that is the administration of fluid. So you just need to read this, that begin rapid administration of 30 ml per kg of crystalloid for hypotension or lactate level more than 4. So these are the two situations where you need to give a bolus of fluid. Bolus of fluid is 30 ml per kg. So now we see which fluid should be used for resuscitation. So there are four options. One is normal saline. Number two, Ringer's lactate. Then we have hydroxyethyl starch, that is HES. And then we can have albumin, human albumin, which is available. What should be used for resuscitation? Which is the kind of best or the ideal fluid for resuscitation in sepsis?
I've started getting some answers, and by now the answers I'm getting are NS, NS, NS. One answer I've got is Ringer's lactate. Another one, Ringer's lactate. Then normal saline, normal saline, normal saline. I think the hands down winner looks like normal saline, but a couple of students or doctors have said that it could be Ringer's lactate.
Okay.
Majority goes towards, I think close to 90% answers are normal saline.
So this answer actually tells us the truth of our resuscitation measures, that all of us have seen and normal saline for long time for resuscitation for patients with sepsis. So it is the most commonly used fluid for resuscitation, but we'll see whether it is the correct way or it is not. So we'll see in next few slides and we'll see the answer to this question. So initial resuscitation will include at least 30 ml per kg of IV crystalloid fluid. So crystalloid fluid means that you are already out with the albumin and starch-based fluid. So you have either normal saline or Ringer's lactate. But the important thing is this amount of this fluid. Amount of this fluid is 30 ml per kg. So if you have a patient who is like 50 to 60 kgs, the amount of fluid will somewhere be around 1.5 to 1.8 liters.